From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Hello and welcome listeners around the world. You're listening to JAMA Psychiatry Author Interview Podcast. I'm your host and web editor, Dr. John Torous. Today we're thrilled to be discussing a new paper just out in JAMA Psychiatry, Cognitive Behavioral Therapy for Mental Health Disorders in Adults, a unified series of meta-analyses. We're about to be joined by the corresponding author of the paper, Dr. Cuijpers, PhD in the Department of Clinical and Neurodevelopmental Psychology at Amsterdam Public Health Research Institute in Amsterdam, Netherlands. Cognitive behavioral therapy, otherwise known as CBT, is a first-line treatment for most mental health disorders and has strong evidence for efficacy, especially in anxiety, depression, even psychotic disorders, and many more. But how well does it work across all these different conditions? And what can we learn about the efficacy of CBT through integrating all of the evidence across different disorders that exist? To learn, we'll explore the results of a brand new study just out in JAMA Psychiatry. So thank you for joining us, Dr. Cuijpers. Let's start by reviewing what, again, is cognitive behavioral therapy. We'll call it CBT throughout this podcast.
Yeah, CBT, I think most people know what CBT is. It assumes that mental health problems are associated with negative thinking about yourself, about your future, about the world. And what the therapy does is change how you think about these negative assumptions you have. Very simply said. I think any mental health problem you can imagine, CBT has been developed and specifically targeted for these disorders. And it's by far the best examined type of psychotherapy across all disorders.
As you said, it's a well-established psychotherapy across so many disorders. So what was missing in the literature that made you and the team do a review of it then?
What the problem is that all these areas are more or less independent of each other. You can, of course, read a meta-analysis on CBT for anxiety disorder or for depression or for a psychotic disorder. But it's not yet done that you do these analyses in all the same way across disorders. And if you do that, then you can also look at aspects that are general across all these disorders. And it allows you also to say, well, how good is CBT depending on the disorder? And so that's why we did it. And also one of the reasons to do this is that we can. Because until now, people did a meta-analysis and they did a lot of work, published it, and then went on with all kinds of other work. But what we are doing, together with a lot of other groups across the world, is developing systematic living reviews across all trials of all psychological treatments. It's a ton of work, but that's why we do not do that alone. Then you can examine the effects of psychotherapies, regardless of the disorder. And I think that's a major step forward. That's really next level meta-analysis. Because meta-analysis there are so many meta-analyses. It's the same problem as why you do a meta-analysis, because there are so many trials that you have to do a meta-analysis to integrate them. But now there are so many meta-analyses that you have to integrate those to understand what the effects of a field are. And that's exactly what we do in this project.
And speaking of, again, we said there's been these analyses, but they're kind of isolated in different fields, anxiety, psychosis, depression. This paper is going to look at CBT across all of them. How do we define all? What disorders are we going to be looking at in this new paper?
Yeah, it's of course not all mental disorders, but many of the major mental disorders are included. It's depressive disorders. We have 4 anxiety disorders: panic, social phobias, specific phobias, and generalized anxiety disorders. We have PTSD, post-traumatic stress disorder, OCD, obsessive compulsive disorder, 2 eating disorders, bulimia nervosa, and binge eating disorders. And we have bipolar disorder and psychotic disorders. So the main mental disorders are included.
To undertake this review, clearly you had to look at a lot of literature for this many disorders. Let's talk briefly, how did you search and screen so many papers across so many disorders?
What we do is we have been developing our meta-analysis on depression for many years. But over time, other research groups are using our methodology to also do the searches, do the analysis, extract the same data, etc., etc. But across all these disorders, we had 100,000 records that we had to go through. And we had 10,000 full-text papers that we went through. And in the end, we included 375 randomized trials. And we were very strict. We only included randomized trials when the participants met diagnostic criteria for these disorders according to a diagnostic interview.
So we get this final 375 studies, which is still a huge amount. Let's talk about what were these papers in more detail, or who was included in them. What does this final sample look like of these 375 high-quality papers?
Yeah, the biggest chunk of papers was on depressive disorders and the smallest on specific phobias. And most of the other disorders had one or a few dozen randomized trials. We included any study in adults. So we did not focus on children and adolescents, but older adults are included.
I'll pause and take us in a different direction, because what's interesting is you looked at considering control conditions. And sometimes this becomes a confusing topic. What is a control condition in a psychotherapy, and why are they important? Why would we need a control condition for talking?
It's a central point also in this paper. If you want to examine the effects of any intervention, you need a control condition to adjust for what happens when you don't get treatment. And for some disorders, that's more important than for other disorders. But for depression, we know that a lot of people get better even if they don't get treatment. And that's much lower, for example, in obsessive compulsive disorder. So that depends a bit, but you always need a control condition to examine the relative effects of that therapy compared to doing nothing. But then the question, what that control condition should be, that's very complicated. That's one of the interesting things we found in this paper. There are quite a few disorders that are almost exclusively examined with waitlist control conditions. And we know that waitlist control conditions overestimate the effect sizes of psychotherapies. If you look at the other major type of control condition, which is usual care, so then you compare the new therapy to what's usually been done in routine care or no treatment. And then you see that waitlist control groups have much larger effect sizes than care as usual control groups. And that's worrying because some disorders, for example, anxiety disorders, but also for PTSD, OCD, and eating disorders, the majority of these trials use waitlist control groups. That means that you only have a few trials in these disorders focusing on care as usual control groups. And then you also see that these effect sizes are much smaller. And that means that all the knowledge we thought we had about anxiety disorders and eating disorders, we should be a bit more cautious about that because it's mostly based on waitlist controlled trials.
Let's discuss what are these main results around how well does CBT work in these different disorders and compared to different disorders?
They all work. And I mean, CBT works in all disorders.
Okay.
You have to be cautious. Of course, it's all research and you're never 100% certain. But overall, it's pretty safe to say that CBT works in all disorders. But in some disorders, it works much better than in other disorders. Especially the effect sizes in bipolar disorder and psychotic disorder are much smaller than, for example, in post-traumatic stress disorder or in depression or in anxiety disorders. But as I said, it's difficult to compare them because what we looked at is the symptomatology of the disorders. If you have a small effect in bipolar disorder, maybe that's clinically, you cannot compare that to the effects on specific phobias because they are not the same thing. They're effect sizes, but effect sizes are still about content. And that doesn't mean that the effects are more important in specific phobia than in bipolar. Maybe a small effect in bipolar is clinically more important than a large effect in specific phobia. So you have to be very careful with these kinds of comparisons.
You said we're saying CBT is effective for all conditions you looked at. We're just looking relative, but again, we know schizophrenia is not OCD. It's very hard to directly compare the two. And I think that's a key takeaway for our listeners too. It's effective. In the study, you had some interesting findings on dropout. I think that's always a concern when people are offering therapy, delivering therapy. Do people get a full dose? What did you learn about dropout?
Yeah, that was one of the nice things we could do because dropout is something universal. That doesn't matter what study it is. I mean, that you can compare that across disorders. I must say that we looked at study dropout. So it's not dropout from treatments, which is something different, which is something that is very difficult to examine because many studies give different definitions for what dropout is. And so we looked at study dropout. And it's important to keep in mind that it's not dropout from the treatment. What we found is that they varied. So they varied from 24% in PTSD to most dropout rates were between 13 and 19%. And the lowest dropout rate was in specific phobias with 8%. So that's not dramatically high. But what we did find is that the relative risk of dropping out from CBT was higher in PTSD and in binge eating disorder.
What do these results tell us about deploying CBT as a universal first step for accessing mental health treatment?
I think this supports the use of CBT for all mental disorders. In most disorders, it is a first-line treatment. And I think this supports that use of CBT as a first-line treatment.
I know you and I personally have talked about digital versions of CBT, and you've written some very impressive reviews in this journal on it. Did this study have any results for digital versus in-person versus self-guided CBT that would be useful to share?
Yes, we included guided self-help interventions. So we included individual CBT, group CBT, and guided self-help. Most guided self-help interventions are done digitally. Usually in meta-analysis, we do not find that guided self-help, so digital interventions through the internet, are less effective than individual or group CBT. We don't find that. What we found in this meta-analysis, when we looked at all studies together, was that group CBT was actually more effective than individual or digital CBT. But these were subgroup analysis, and you have to be very cautious with subgroup analysis in meta-analysis because they are not causal evidence. It is very well possible that there are a few, one or more other characteristics of the studies that explain that you find that group CBT is more effective, but in fact, it's another variable that explains it. So you really have to be very cautious with it.
You helped us explain why control conditions are so important to study. Let's briefly talk about those results that you found around control conditions and how they can inform how we deploy or kind of run different CBT research studies.
Yeah, well, what I think is important, especially in the fields where a lot of waitlist control groups are used. So the anxiety disorders, PTSD, OCD, eating disorders, that these research fields move more towards other type of control conditions. I think that's really very important to make a good assessment of the actual effects of CBT for these disorders. I think many studies have been done in depression. And in depression, we have a very nice mix of waitlist controlled studies, carousual controlled studies, and all kinds of other, even pill placebo control conditions. What we see there is that waitlist control groups clearly overestimate the effect sizes. We see that also in the other disorders. For some of the other disorders, we actually only have a handful of trials using other control conditions than waitlist. So I really think it's very important that in those fields, other types of control conditions are used.
So it sounds like we have to begin to move beyond these waitlist control conditions to really understand what we're delivering and how to make it better in the future.
What probably happens in waitlist control conditions is that people are stimulated not to do what they usually do when they have a problem. When you have a problem, you usually start coping with it and you try to solve it. You talk with friends, you start reorganizing your life or whatever you do. But when you're on a wait list, you think, I have to wait 2 months and then I get this fantastic treatment. So I'm not going to change anything because in 2 months I get this new treatment anyway. And then everything will be better. We examined that in depression in another paper. And there we found that rates of response in waiting lists were lower than in carousual control conditions.
That's fascinating. And clearly you have a lifetime of impressive work in this space, looking at different therapies, how well they work. What is coming next, or where are we going? If you had to say kind of all the work you've done, where you see the field, what would be your expert next steps? We won't hold you to predictions, but where are we going?
There are many different directions. A lot of people are working on innovating the field. I think you are one of them. And I think if you look at all the different areas where we can expect innovation, that's in the digital field, obviously, that's big. We have these AI applications, avatar therapy, just-in-time intervention. So there's a lot of things going on in the digital field. There's a lot of things going on in the stratification and personalization of treatments. There's a lot going on in new and improved therapies. And then we have a challenge that a lot of people do not get an evidence-based treatment, especially in low and middle income countries. So we have to simplify therapies, and there's a lot going on there too. When you look at all these innovations, what we should expect is not a silver bullet. There will not be a silver bullet that will dramatically result in better outcomes and change mental disorders for once and for all. What we have to focus on is small incremental improvements in better treatments, in faster treatments, in getting treatments to the people who need it. And it's not one thing that we will personalize therapies will dramatically change everything. No, they have the potential to improve care, but only with small incremental steps. And that's what all these innovations will be doing. That's how I see the future. It's a lot of work, but we can get there. We can make things better.
Coming from, again, an expert like you who just looked at this from so many ways for so long, I think that's sage advice for us all to take. And I think, again, this paper that you and the team have put out is a really nice new standard to understand how these therapies work against each other, waitlist control. So thank you so much for chatting with us. I'm John Torous, and I've been speaking with Dr. Cuijpers about CBT for mental disorders in adults, a unified series of meta-analysis. To learn more about this research, you can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at JAMA Network. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.